Welcome to another special episode of Cancer Buzz. ACCC is working to deliver resources to help you deliver cancer care during the coronavirus pandemic. Last week, we spoke with Dr. Chad Peterson, a medical oncologist in rural Montana. He had a specific set of challenges in his location. Today, we head to New York City. Dr. Luis Isola is the Director of Clinical Cancer Programs for the Mount Sinai Health System in New York City. Dr. Isola, for the measures that have been taken to alleviate the tremendous burden on the New York City healthcare system, for instance, the Mercy Ships, the Central Park Respiratory Care Unit, and the Convention Center, have any of those things helped your particular healthcare system?
So unfortunately, only marginally. Clearly, the arrival of the ship and the opening of this space in Javits was initially accompanied by a lot of enthusiasm, thinking that, this was going to provide several thousand badly needed beds to accommodate our COVID positive patients. We then learned that both the ship and Javits, initially at least, were not meant for COVID positive patients, and that there were, significant restrictions as to the acuity level that those facilities were able to accommodate. So, to make a long story short, rather than thousands of patients, we were really able to only accommodate a few hundred patients between Javits and the ship. On the other side of that story, the peak that we were expecting was significantly flatter than initially anticipated. And hospitals in New York did an extraordinary job, including my own hospital, to surge numbers of beds and number of ICU beds and ventilators. So we were able to really, deal with the onslaught of highly acute and critically ill patients without having to count on the ship and the Javits facility.
What has been the impact on your cancer program? Have you had to close clinics or transfer patients to other settings or utilize telehealth, for example?
To some extent, all the above. We've done extensive use of telehealth to see patients who needed routine follow-up visits or to have results discussed and therapies adjusted. We transitioned a number of patients from intravenous to oral therapies. We made extensive use of neoadjuvant therapy to delay surgery. But, through the entire crisis, we stayed open and we took care of patients both on the ambulatory and on the inpatient side. And we were able, thank God, to take very good care of oncology patients.
What about staff? Have any been reassigned to help care for COVID patients? Have you had a lot of illnesses in your own staff?
Unfortunately, the answer was yes to both. We did have to redeploy a number of physicians, attendings, trainees, and providers such as nurse practitioners and physician assistants to the COVID positive units. And just to give you a little bit of a sense, normally we have about 10 teams covering medicine. At Mount Sinai Hospital, we had to increase that number to 40. So obviously we had to redeploy a large number of providers.
What does the telework situation look like? Are there positions that can work remotely?
Well, as they say, necessity is the mother of invention. And if you go back to the beginning of this year, routinely we would do, a handful of telehealth visits a week, maybe, single digits, say 5, 6. You're looking at it now, we're doing somewhere around 500 to 600 telehealth visits a week in oncology. So physicians have become very adept to using it. Patients have become incredibly accustomed to doing telehealth visits. Some of the intricacies in oncology is that we frequently need laboratory values to see patients and make decisions. And, if a patient is going to stay home, say in Long Island or in Staten Island, those laboratories have to be obtained. So frequently we ask our nurses to send prescriptions to patients. Patients end up going to local laboratories, getting those labs. The labs come back. There is a little bit of extra work and different workflow than we're accustomed to, but we make it work.
What are you doing to keep your staff healthy physically and mentally?
Well, the first part is easier than the second. People are coming back to work. They're staying busy. They're staying home. They're keeping, social distancing. They're very respectful of that. They're using masks. They're using PPE as appropriately. So we've been, by and large, pretty lucky about keeping the vast majority of our staff healthy. In terms of the mental piece, this is going to take a tremendous toll on mental health. When we look at things like 9/11, the incidence of post-traumatic stress syndrome after an event like 9/11 was calculated to be somewhere around 20%. This is going to be worse. There's going to be a lot of anxiety, depression, and difficulty sleeping and nightmares and all the things that accompany PTSD after this. The health system has developed an institute for resilience and personal growth, which is dedicated to taking care of that aspect of this pandemic. And we're going to take care of our own. We're going to make sure that, those provider staff and support staff and in general, all the staff that are going to come out of this pandemic with serious psychological distress are appropriately taken care of. I think this is going to lead to a very deep re-examination of our dogma, which has been very pervasive in the last few years. Ambulatory medicine is largely going to replace hospitals. Hospitals are the dinosaurs of medicine. They're going to become obsolete. We're going to have to rethink that because clearly we were not prepared for this, and we were not prepared to surge our bed capacity by 100% in a few weeks. We are not going to be able to keep our hospitals at 100% capacity going forward.
Cancer programs and practices in all care settings, urban, rural, and everywhere in between, are working to ensure that their patients receive high-quality care in the face of this pandemic. Thank you for listening. Next week on Cancer Buzz, how to make telemedicine work for both providers and patients. Until then, for the Cancer Buzz team, I'm Summer Johnson. Stay well.